This is Mobility Week 2. Next week, week 3, we have exam 1, which covers modules 1 and 2. It's a 50-point test, and the study guide has been posted in module 2, but I will also be bringing a copy to class because we're going to be working with it tomorrow in class. The goals for this concept is to define and describe the concept of mobility, notice risk factors for impaired mobility, recognize when an individual has compromised mobility, and then provide appropriate nursing and collaborative interventions to optimize mobility and minimize complications of mobility. Mobility is a state or quality of being mobile or movable. Functions of the bone, they are there to support the structure of the body, provide our form, and also allow us to actually move. Elements of musculoskeletal assessment. For their history, you want to look at what is their past medical history. Does their family history have some type of musculoskeletal disorders, current medications they may be on, any lifestyle behaviors, occupation that they're doing, their social environment, and any problem-based history. Common symptoms that you can see with altered mobility are pain, reduced joint movement, reduced sensation or loss of sensation, falls, fatigue, altered gait or imbalance, and a reduced functional ability. Pain is the most common symptom associated with musculoskeletal complaint. Questions that we need to be asking the patient are what type of pain are they having, where is it located, what's the severity, what is the duration, and what are precepting or alleviating factors. Physiological changes we may see as the older we get, the bones become thinner and weaker, and this is what they call osteopenia, which is a presence of less than normal amount of bone. And osteopenia, if it gets left untreated, becomes what we call osteoporosis. So anyone that is being looked at as being osteopenic, we need to make sure that they are doing treatments, taking vitamins to get themselves so that they're um, not leading to osteoporosis. Then we have some laboratory tests that can be related to musculoskeletal disorders, like an acid phosphatate. Will do Paget's disease, checking on erythrocyte sedimentation rate, or sometimes you'll hear it as a ESR or a SED rate. Tests for inflammation, hematocrit, hemoglobin, or red blood cells will evaluate for anemia or extend a blood loss. And then uric acid we'll use to diagnose gout. Radiographic studies that we may do is angiogram. This is often used after trauma or surgery to confirm DVT or a PE, or just what damage has been to an injured area. Um, Arthrography, knees and shoulder injuries are commonly assessed with this method. Bone scan is used to detect early bone disease, bone metastasis, and bone response to therapeutic regimens. They can detect fractures, abnormal healing fractures, and degenerative bone diseases. CTs, they use these to see tumors and fractures, and then an MRI is used to confirm diagnosis of a musculoskeletal dysfunction, and it can also be used to diagnose infections. Osteoarthritis, it's a non-inflammatory degenerative joint disease. Symptoms are pain and stiffness, especially after prolonged activity. Gait disturbance is common, and these patients are at increased risk of falls. There's two types. There's idiopathic or primary, and then there's secondary. Primary, there is not a cause, no on cause that's known, and secondary is usually related to a known trauma in that area. Could be prolonged mechanical stressors like obesity or athletics, inflammation in joint, but it's not related to rheumatoid arthritis. And usually one presents in only one joint, so it's asymmetrical development. Osteoarthritis symptoms, you'll have joint pain, which is the most common, tenderness, warmth and swelling, which is usually seen in the early disease, limited movement. You'll hear some crepitus, some crackling, crinkly crackling or grating feeling or sound. Um, Heberden's nodes, which are hard nodules or enlargements of the tubercles of the last phalanges of the fingers, and Bouchard's nodes, which are body enlargements of the proximal interphalangeal joints. And there's a good picture in the textbook that shows this. Diagnostic testing, there's no specific laboratory testing, but MRI is the best for identifying the progression of the joint damage. Management of osteoarthritis, you want to maintain joint mobility and minimize their pain and inflammation. You'll use pain medications or non-pharmacological methods along with passive active range of motion. The strongest risk factor for osteoarthritis is overweight and obesity, and they can use vitamin D, phosphorus, calcium, selenium, proteins, and iron to help keep the joints healthy. Pharmacology, they'll use Tylenol, NSAIDs like ibuprofen, naproxen, Indocin, Feldene, and Relifen. If they're not able to take NSAIDs, then they'll use Celebrex. And for Celebrex side effects, you need to watch for if the client reports that they're having black, dark colored, or tarry, um, or bloody stools on abdominal pain or coffee ground emesis, they need to report that this is happening. Gout, it is a metabolic disorder which affects primarily men. It shows elevated urate levels and it has a hereditary tendency. Symptoms of gout are rapid development of pain and edema in one affected joint. Risk factors can be trauma, alcohol use, medications, acute illness, or family history, and they may have decreased range of motion in the affected area. They also can see fever, headaches, and hypertension may be present. Diagnostic tests, labs will show elevated uric acid levels. The urine albumin will be increased. They can see elevated urinary uric acid, elevated sed rates, and leukocytosis could be present. Labs commonly done due to systemic complications from chronic hyperuricemia, and usually the ones that are done are CBC, serum creatinine, serum uric acid, BUN, and urinalysis. Management of gout, you want to treat the arthritis symptoms first, so the pain and the edema, and then you treat the hyperuricemia second. They should have diet low in protein, purines like refined cereals, white bread, pasta and flour, milk and products, sugars, sweets, gelatin, all fats, nuts, and peanut butter, vegetables other than what is listed below, and then cream soups. And this is the ultimate diet that they should have. Getting to the moderate purine foods is beef, chicken, duck, pork, ham, shellfish, asparagus, mushroom and spinach, and then kidney beans, lentil, and lima beans. The worst foods that they can have, which are high purine foods, and they should avoid them, is alcoholic beverages, anchovies, sardines and herring, codfish, trout and haddock, mussels, scallops and oysters, turkey, veal, venison, and any type of organ meats, and bacon. Pharmacology, there are 4 categories. One is NSAIDs, which is the drug of choice, treat pain and inflammation. Indomethacin or Indocin is the drug of choice, and those who can't take NSAIDs are prescribed Celebrex. And then there's the gout medications. It's used to treat the acute attack and prevent further attacks, and it's colchicine. It's used for the attack. Allopurinol, probenecid or anterine helps lower serum uric acid levels. Fibromyalgia, it's a clinical condition that involves chronic widespread diffuse musculoskeletal pain, stiffness, and tenderness, and lack of restorative or deep sleep is a contributing factor and symptom of the condition. Symptoms: to be diagnosed with fibromyalgia, there are two criteria that have to be satisfied. You have to have widespread pain that has to have been present for at least 3 months, and then there also has to be presence of a second clinical disorder that does not exclude the diagnosis of fibromyalgia. Um, Widespread pain is pain that's bilaterally and it's above and below the waist. So if it's in one shoulder, it should be in the other, one buttocks, the other buttocks. So just make sure you know it's the pain is bilateral and it's above and below the waist, and that's part of the diagnosis. Management: the main treatment is to alleviate the pain and manage any other symptoms, conditions, or contributing factors that are showing. Use both pharmacological and non-pharmacological therapy. Non-pharmacological would be to restore sleep hygiene, increase physical fitness, and eliminate any psychological distresses. You need to make sure to use active listening skills, as most often these patients don't feel like they're being heard. Work with the patient to support their self-esteem, self-efficacy, and independence. And then physical deconditioning is a commonly seen in fibromyalgia, which is why it's important that they do physical fitness, because we don't want them to decondition down. Pharmacology: use analgesia, antidepressants, and muscle relaxants. The antidepressants help improve sleep, fatigue, and pain severity. Meds seen are amitriptyline, cyclobenzaprine, fluoxetine, and amitriptyline combination, citalopram, and tramadol, and sometimes they will get lidocaine injections in trigger areas. Okay, osteoporosis. It's characterized by low bone mass, microarchitectural deterioration, compromised bone strength, and an increase in a risk of fracture. Major risk factors include personal history of fracture as an adult, low body weight less than 127 pounds, anyone that's currently smoking, anyone that's been on an oral corticosteroid therapy for more than 3 months. Minor risks: impaired vision, estrogen deficiency at an early age, younger than 45, dementia, poor health or frailty, recent falls, low calcium intake, low physical activity, alcohol in amounts greater than 2 drinks per day. Excessive consumption of caffeine and alcohol are risk factors for primary osteoporosis because of the loss of calcium that goes out in the urine. So you want to watch out for how much caffeine you're drinking. Symptoms: most people do not even know they have this disorder until they suffer a fracture. Another symptom that is seen is a decrease in height, which may be accompanied by kyphosis, which is hunchback. Common fracture sites are forearm, femur, ribs, and the spine. Diagnostic tests: x-ray is done to rule out a fracture, and a bone mineral density test is done to rule out the osteoporosis. The gold standard to determine bone mineral density and diagnose osteoporosis is a DEXA scan. Nutrition and pharmacology: they want them to take an intake of 1,000 to 1,500 milligrams of calcium a day. They may put them on Fosamax, Actonol, or Beniva. Side effects you may see from these meds are jaw pain, blurred vision, and drowsiness, and you need to make sure you're taking these. They're called biphosphamates with a full glass of water. Osteomalacia is a metabolic disease that causes poor and delayed mineralization of the bone cells in mature bones. There's a softening of the bone. Main cause is vitamin D deficiency. So your Risk factors are diet deficient in vitamin D, low endogenous production of vitamin D, which is the lack of sunlight exposure. They may have malabsorption, renal tubular disease, and anticonvulsant therapy. Symptoms, they have generalized skeletal pain and tenderness. Usually there's no injury that's happened. They low back pain, hip pain, rib and feet pain, and they also will have a waddling gait. Diagnostic tests, serum calcium phosphate, alkaline phosphatase, parathyroid hormone, 250 hydroxyl vitamin D, BUN, and creatinine. Testing else they do is bone densimetry and x-rays. So they're going to look at the bone density and they're going to look at x-rays to see at what extent the osteomalacia is. Pharmacology, they might do vitamin D supplements and sunlight exposure, and then they also can, if they need more than just the vitamin D, they'll treat them with vitamin D2. Paget's disease, it's the second most common bone disease after osteoporosis. The pain is similar to arthritis, so it's really difficult to diagnose, and there is no chronic bone, this is a chronic bone disorder that has no cure. Symptoms you may see are usually or symptoms they may have are usually asymptomatic. If they have pain, it's mostly in the hips and the pelvis, and it's a deep aching pain that worsens with weight bearing. They can also have bowing of the long bones of the arms and the legs, and this is pretty common. Diagnostic testing, they would do a serum alkaline phosphatase. It's looked at. You see an increase in this and Paget. A normal serum ALP is 30 to 150 units per liter. So if you see an increased one, this will give an indication. They also use x-rays and bone scans to test for it. Pharmacology, they're going to be on biphosphonates, so like Diadrenal, Fosamax. It needs to be taken on an empty stomach with 6 to 8 ounces of water, and then you need to make sure they don't lie down for at least 30 minutes after taking the dose. Body mechanics, this is the way we move our bodies. We have body alignment, balance. There's 3 different ones. You have your line of gravity, which is an imaginary vertical line drawn from the top of your head through the center of gravity. It's within the base of support. You have your center of gravity, which is below the umbilicus at the top of the pelvis, and then your base of support holds the body up. The feet provides that base. You also have coordination and you have joint mobility, so range of motion, whether it's active or whether it's passive. And to review for the tests, know how to use crutches going up and down the stairs, what signs are associated with immobility, prioritize what patients you would assess first coming onto a shift. How do you assess for presence of thrombosis? What is the purpose of anti TED hoses? And what intervention helps prevent falls in an older client?